I welcome all the panelists. I think Dr. Ram is not able to join us for a personal emergency, so we have all others here.
Yeah, hi, I'm Dr. Gargi.
Hi, Dr. Vamshi here.
Dr. Rakesh, urologist.
Deepak, radiation oncologist.
Saurav Vashish, urology.
Okay. So we begin with the panel discussion. So these are the abstracts we would be covering in this panel discussion, and going to the first abstract first about the precision point transperineal access system. So my question is to the uro-oncologists here with us, Dr. Rakesh and Dr. Saurabh. So what comprises your practice? So when you do a prostate biopsy, what is commonly done by you?
As of now, standard transrectal 12 to 13 core with targeted biopsies of the lesion.
Okay.
On the
And
MRI.
Okay.
MPMRI is done the prior.
With the cognitively
cognitive.
fused
Yes,
MPMRI.
Yes.
Sir, the same. Have you all ventured into transperineal biopsies?
No, I don't have any.
Anyone maybe from the audience who is doing transperineal biopsies would want to add? Yes. Hi. Okay. Yeah, I think so. If we could hand the mic to them, please. I'm a radiation officer.
We switched over to transperineal last more than 1 year, and almost 90% of our biopsies are transperineal now. What we see is retention rate is slightly high, infection rate is very low, and the pain component is one factor. We are doing it under anesthesia because majority of our patients, they are comfortable with the anesthesia rather than local because they are apprehensive about that.
Okay.
No, I
So,
just want to make a comment.
yeah.
Although it is very good and I don't have personally any experience about it, but I think a very specific subset of patient qualifies to have a transperineal biopsy in an Indian scenario where most of the time we are getting the disease which is rectally palpable. And on MRI, if the disease is
I'm
mainly in the
coming-
mid zone or this, I don't think so that
I'm
it will
going to come to that, yeah, in the relevance of it in our setup, but yes. So I think with transperineal biopsies, there are a number of procedures. There's freehand, there is precision point, what this talks about, and there is grid-based. So personally, actually, we've been doing in our institute grid-based transperineal biopsy with not much of a problems as compared to freehand also. So, any problems in any areas of transrectal biopsies where you feel that these cases are the ones where I don't want to go ahead with a transperineal, a transrectal, and should be, if I have the opportunity and the system,
I think
transperineal?
if the disease is mainly anteriorly placed, then it will going to make a sense and it will going to increase the positive predictive value of the procedure by doing a transperineal biopsy. But if the disease is in the peripheral zone or in the mid zone, I don't think so it will going to make any difference.
Okay, so your experience?
We at cancer centers, generally we get larger volume disease only. Very rarely we get the screen detected patients. So never face such problems. Transrectal has been doing good. But we want to switch. The problem is the anesthesia part.
Anesthesia. So, as someone mentioned from the audience that they do it with anesthesia. Actually, this
So generally what
trial,
happens, whoever I've spoken, they have started the program. Initially they start under anesthesia, and once they are accustomed to how to handle that, then they move on to the local based procedure. So initially you need anesthesia too, because you are yourself learning, so that time you take more time.
So Dr. Ashwin is here who presented. I think he has some experience on transperineal precision system from what I've heard. So you did it with anesthesia or local anesthesia? Okay. Okay. So the cancer detection rate overall, what they showed in the study was overall and the clinically significant disease was 68% and 42.6% respectively. These are good numbers, but the variability, you know, when he showed the trial was huge. For overall, it was as much as 40 to 80% or 85%, and for clinically significant disease, it was less than 20 to more than 65%. So what could be the factors that can affect the cancer detection rates in this type of biopsy? Like in terms of the technique, what is it that can change these numbers?
So I think mainly if we are dealing with the anteriorly placed cancer and trying to hit with the transrectal approach, there is a...
Yeah, I'm talking about the difference, variability in studies of precision points. So transperineal biopsies are having these ranges. Of course, one is a learning
I think
curve.
learning curve is
Other than that,
important.
anything that you think could influence these numbers?
I don't think so.
Okay, anything? So maybe a pre-biopsy MRI with cognitive fusion or a system-based fusion and pre-biopsy PSA levels are some. So one of these studies which had only a 20% detection rate, they actually, in the entire review, we don't come to know, but they were actually re-biopsying previously negative ones. So we are expecting them to be negative just on the screening and surveillance. So that could be the difference, and the MRI could add. And
Dr. Ginil wants to speak.
yeah, please.
Axial, so we get a better yield of prostate tissue when we are entering coaxial with the urethra. So I was not initially thinking that this can give that much of difference, but we and our pathologists feel that the yield is definitely increased even though we haven't studied. Wherever we are having a rebiopsy also, we could better. So probably that is not the anterior aspect alone. Actually, in the peripheral zone also, when we are going coaxial, when we are going from the transrectal, we are getting a small sample from the peripheral zone. But when we are going coaxial, we get a better sample along the axis of the prostate. That is why probably the yield is better.
Okay. So, but so I am used to using a grid-based transperineal. At Hinduja, we do grid-based. So in transperineal access, you do not face any problems
Actually,
in
freehand is
maneuvering it
better
to...
for us. Freehand is better for us for biopsy at least, but for brachytherapy and all, grid-based is better. But freehand, the advantage is, according to MRI picture, we can change the axis and target the lesion better with freehand.
I would just beg to differ on this one. I agree that the difference or the betterment of freehand versus grid would be the local anesthesia that you can do it with. But otherwise, we can also use the MRI with cognitive
That is
fusion with the new
why
software.
from one axis we can target the lesion, one point of entry we can target the lesion with freehand. And when you are experienced in correlating with this thing, there is no issue to hit that lesion in whatever angle we want. So what I feel is grid can restrict that movement of hand.
We have multiple
maybe.
entry points.
Yeah.
Of course, that is, of course, a critique that has been raised against the grid system, that you multiply puncture the individual, and which is not warranted if we can do with a single puncture. And so would you decide on the technique based on the situation? So in surveillance versus initial staging, it has been known that surveillance, the upstaging... Sorry, is everything okay? Yeah. So surveillance, of course, as you mentioned, as per the location on MRI, you would select transperineal and anterior situated. And any difference in your preference, if you had, everything available to you, between surveillance biopsies and the initial staging biopsies? Because this paper talks of an improved upstaging when we do transperineal as compared to...
Makes sense if we are looking forward for a surveillance biopsy, because there we are looking more forward to look forward for the cancer detection rate, and we don't want to miss them. So I think if first transrectal biopsy is negative, it is better to go for a second transperineal biopsy.
I agree.
Rather than other way around.
Yeah, so maybe when we are starting off as a system, those are the indications where we should first start off and then gradually,
So it is just like that the initially transrectal biopsy is done on the basis of cognitive based, but later on, if it is negative and you are having a high suspicion rate, you will like to switch over or offer a MRI transfusion guided base. So I think that's the same thing.
Okay, thank you, sir. Gargi, in TMH, what is the general practice? What are you all doing? Of course, the
We are
urologist.
doing transrectal exclusively.
Commonly
Yeah,
for
yeah.
everybody. Okay, thank you. So, 89% of the times in this study, the procedure was done under local anesthesia. I think I have one doctor here who's talking about transperineal. So, and beginning with GA is preferred, and then probably we would move over to local anesthesia is what I got as an answer. So we talk of less sepsis rates with transperineal biopsies, less complications. So of course that means transrectal has their own share of complications. As a surgeon talking to others, the radiation and medical oncologists, could you brief what exactly is the sepsis rate and how bad it becomes, and a little bit of the general information you can share with all of us?
Generally, all the precautions are taken, the pre-procedure precautions, but still these patients might be having some resistant organisms and acute prostatitis.
So
can
one
be
in
the
how
case.
many you feel actually develop some infections, and one in how many goes into a
It's less than
sepsis?
5% actually. We don't see that commonly, but every patient will have some low-grade fever, all those things.
Low-grade.
They might end up with a significant acute urosepsis also.
So that means that is a valid point then to gradually shift to transperineal biopsies if your local incidence is...
I will like to make a comment. Like
Yes.
in my entire experience, I have seen only 2 patients of sepsis after the transrectal biopsy. But I think the difference in numbers and the practical situation is why? Because what we talk about as a prophylactic antibiotic, we talk about either gentamicin or ceftriaxone only. But I myself has experienced this, that in most of the centers, they use piperacillin, tazobactam, even up to a meropenem, including amikacin, metronidazole, ofloxacin, everything. So I think in what they are talking about having a 5% infection rate, because when they are using a standard antibiotic, what we are not seeing practically, because most of the time, very high-end antibiotics are used. They start patient on antibiotic 2 days before. They give IV antibiotic at the time of the biopsy. They continue it for next 5 to 7 days. So practically as such, I have seen only 2 cases in my entire career.
Okay. And the next question, feasibility in our Indian setup. We were once in our journal club discussing the cost of a transrectal versus a cost of a, we have grid, so grid-based system versus precision point. So any comment on the feasibility in our Indian setup based on cost effectiveness? Of course, the trial talks that, ultimately it is cost effective because of the low sepsis rates. But overall, as an initial procedure, do you think it's cost effective in our
I think
setup?
so. It should not be a problem. The cost, unless you're using GA, means anesthesia has been given.
We are going to use GA in our
So if
initial
you're going
learning
to
curve.
use GA, definitely the cost will rise, depending on center to center.
So, okay, so cost-wise, while the study says that precision point will eventually turn out to be cost-effective, what we had discussed is that as compared to transrectal, the cost in Indian setup is a major issue that hinders its uptake. Coming to the next 2 studies, I've just taken 2 studies together about salvage radiation therapy after radical prostatectomy and made a small case about it. So these are the 2 studies presented just now: impact of PSMA PET-CT and prostate cancer salvage RT management, and impact of PSMA PET-CT on, sorry, I've put the same 2 ones, but on the use of apaletomide and abiraterone in the salvage setting. Sorry about that. So case 1, 65 years old gentleman evaluated for urinary frequency and ultrasound shows an enlarged prostate. His PSA is 24.2. Biopsy showed prostatic SNR adenocarcinoma with a Gleason score of 4+4, 8 in 2 cores. Remaining all cores were positive but showed a Gleason's of 7. PSMA PET-CT was done. Prostate measured 3.4 centimeters in max diameter and shows heterogeneous enhancement. PSMA avid lesion of volume 25 cc and involves seminal vesicle in midline. Everything else was normal. There was a little bit of tug of war. I'm not going to ask you on what you would prefer because we'll move on with the case. The patient went to a radiation oncologist outside, not in our setup, was started on neoadjuvant hormone therapy, but patient took an opinion of a uro-oncosurgeon and went ahead with radical prostatectomy. after 1 cycle of ADT. So patient underwent robot-assisted laparoscopic radical prostatectomy with bilateral pelvic lymph node dissection. And so while we await histopath report and before we move on to salvage, my question is to the two radiation oncologists here and the surgeons, because you're going to refer to us, any factors you look for to suggest immediate adjuvant treatment in the histopath? What are you expecting?
We'll first look for the histopath report, look at Gleason scoring. We'll look at how many cores have been taken and how many percentage of cores are positive. And then PSA level.
Well, I'm talking about a radical prostatectomy has been done. We are waiting in those 4 days for the report. When are you looking for any pointers in your brain that, if this patient has these factors, maybe an early radiation versus a salvage would be better? I want to treat immediately. Or the surgeon wants to refer immediately.
Yeah.
So basically, we'll look into the margin positivity. We'll see T3A, T3 is already T3B clinically. Margin positive lymph node positivity is there, and those are the mainly two criteria we'll see. Depending on that, we'll decide on the adjuvant. Plus, we'll look into the first PSA, which is done at 4 to 6 weeks interval.
Okay, so nothing immediate you're looking at. Gargi, any comment on early adjuvant versus waiting for salvage?
Yeah, so we would definitely wait for the final histopath, but since this patient had a Gleason's of 4+4 and T3B disease and PSA, I think of
24.
More than 20, I would feel he's likely to require adjuvant therapy.
Okay. So this patient, the histopathology report was right lobe SNR adenocarcinoma Gleason 7, 70% lobe involved, and seminal vesicle was free. Left side made it T3B because left seminal vesicle was involved, PNI positive, and Gleason's again 7. Pelvic lymph nodes 7 retrieved, all free. Patient was on regular follow-up and PSA at 1 month was 0.01. Thereby, 7 months later, PSA is 0.28 and 1 week later, 0.36. Dr. Abrol, what would you want to do now?
I think, can you just put
Yes,
on the
please.
previous
Yes.
slide?
Yeah.
Since Gleason score is 4+3 and previous PSA we have seen 24, it's coming into intermediate risk group. So we will take him for up for adjuvant treatment, RT with ADT.
Okay. Gargi, any thoughts?
So, though not a radiation oncologist, but looking at this high Capra score, you have a seminal vesicle. Wouldn't this be a candidate for actually a adjuvant RT? I mean,
Yes,
not a
it
salvage.
It would be. But then that's why I asked initially that,
That's what I
factors
told
would you look
adjuvant
for? Yeah.
RT.
But then this patient per se, this is a real case scenario, had, undergone waiting, and then 6 months later when the PSA rose, salvage RT was initiated, and I'm looking forward to take that forward.
In this scenario, I think one more important thing is the yield of the pelvic lymph nodes. They are very less.
Okay.
So that also has to be seen in view of seminal vesicle involvement, the volume of the disease, and inadequate lymphadenectomy.
Okay.
It all justifies to start a RT as soon as possible, adjuvant setting, rather than waiting till that much of time. Because these are the indicators where we should look forward for the adjuvant RT, even though if the PSA is less. Because these are the patients who will going to fail very soon. And then when the salvage RT will be started, at that time, the outcome will not be as good as it should be in the adjuvant setting.
Gargi, any difference of opinion?
Yeah, in this patient, I would go for
Go ahead with
adjuvant
immediate
RT.
adjuvant
Yeah.
RT. Okay.
Yeah.
Yeah. This patient had a number of high-risk factors which would point towards immediate adjuvant RT. But coming to the case, this was what happened, and this is when 7 months later, patient came to us at our hospital, and the PSA was 0.28 and 0.36. So now, would you want to start? Patient has not received any adjuvant radiation. Would you want to advise radiation?
At this point, yes. We could also do a PSMA PET scan to rule out any extra pelvic disease. But yes, at this point, we should go ahead with radiation.
Yeah. So patient was planned for salvage radiation therapy, and as you correctly mentioned, PSMA PET CT was done before planning salvage RT, and now is the standard of care before all salvage RT plannings. Is that correct, in your opinion? All patients of salvage
yes.
RT?
Yes.
According to you as well? Okay, that's it.
What would be the sensitivity of a PSMA PET with a PSA of 0.36? You know, this is a discussion we have in our MDT. There's the number of cases you're going to pick up extra pelvic with 0.36 PSA. I don't know if anyone can call it. I mean, less than 5%.
Since the patient is on follow-up, we have just watchful waiting ही चल रही है. So that's why I think PSMA PET
But
is
with a
required.
PSA of 0.36, what is your expectation? It will be local recurrence, yes. But a PSMA will...
But previously when biopsy was you saw.
I got your point.
Actually, PSMA PET CT in this setting will going to help you out to decide whether the systemic treatment should also be added with this patient or not, because here we have not done an adequate pelvic lymph node dissection. So that will going to help us in two aspects, whether to include the pelvic lymph node field in the radiation also or not, and secondly to consider for the systemic therapy.
Exactly where I'm coming, because our article also talks about minor and major changes that PSMA PET CT has brought about. And PSMA PET, as Dr. Krishna, you mentioned that. So studies show that there is a 50% detection rate of some focus, although clinically in practice, I have not seen so many foci being picked up, and including this case. So PSMA PET CT was done and it was absolutely normal for this patient. No PSMA avid local, regional or distant disease. I would request one of the radiation oncologists to take this question. Would you elaborate on the volumes?
Hello.
So we would... Sorry, sir.
Sorry. One comment. I don't know whether you recall 2003, Dr. Patrick Walsh had given his information on 3,000 radical prostatectomies. And he had clearly said that if the seminal vesicles are positive, you should treat the disease as a systemic disease rather than loco-regional disease. I do not know whether the concepts are still there. But that would solve all these problems, that this patient requires to be treated like a systemic disease rather than then the question about, you know, node number of nodes, and they will have no meaning perhaps. A lot of people used to believe that lymph node dissection was only for staging and not a therapeutic benefit. However, we have progressed because the morbidity was low and everything, so making it believe that lymph node dissection is a therapeutic benefit. But these are the 2 points I want you to consider. Thank you.
Can I make a comment?
Yes, please. Yes, sir.
Jagdish, what you said about 2003 is right, but things have changed a lot. Seminal vesical invasion is again divided into 4, type 1, 2, 3 and 4. That is number one. Second thing, it is not only seminal vesical invasion alone is not enough. Grade of the tumor, the stage of the tumor, and all those factors have to be combined together. Then you take a conscious decision whether you have to start the systemic therapy or not. But local radiation therapy, my answer is yes, it has to be given.
I think sir is right, because considering the impact of the morbidity of the systemic treatment in terms of hormonal treatment, and that too without any evidence on any imaging, I think it is not justified to start. But yes, it holds true today also that he is a candidate, but with some evidence in our hand.
Excuse me. We also have to look at the PSA doubling time. In this patient, it is changing in a week time from 0.28 to 0.36. The doubling time I calculated is 1 month. Such cases will are more likely to have systemic recurrences happening rather than a local recurrence, despite you having adverse pathology. So I feel that this patient should receive some form of systemic therapy as well, even if the PET does not show any foci of disease at present.
So systemic therapy, you mean the concurrent one with ADT or something beyond that?
Personally speaking, I would just give ADT in this patient.
Without
not
radiation.
give radiation therapy.
No, so
Yes.
for EUV recommendation for such patients now, EUV recommendation is
Can I just...
you have to start ADT with abiraterone for a period of at least 2 years.
Patients who've had radical prostatectomy, the thing is, there are 3 randomized trials. Adjuvant radiotherapy versus early salvage radiotherapy treatment. There's a meta-analysis, artistic meta-analysis. There is no difference in the 5-year EFS, whether you give adjuvant radiotherapy upfront or you wait for the early relapse to take place and then you give. So for a motivated patients where a surgeon is telling the patient that the thing is we can observe you, we'll serially monitor your PSA test, and you detect an early recurrence and you give radiotherapy, there is no difference in the outcome. For an unmotivated patient, for patients with multiple risk factors, follow-up is unreliable. The thing is, you may consider adding adjuvant radiotherapy treatment.
Also, one more comment, please. We already talked about incontinence after radical prostatectomy. So in the current scenario, usually adjuvant radiation you are not able to offer because the patient is not continent by this time or may have some form of incontinence. And you're more likely to actually give him ADT and wait the time till you get to the point where you can add radiation to this patient.
Hello.
So,
Yeah.
So that is what I'm saying. Before contemplating whether radiation can be added, there should be a statement that the patient is continent.
Yeah, so in most trials that have studied adjuvant radiotherapy, they've allowed radiotherapy to be given within 6 months of surgeries. I think most patients become continent well before that.
But that is what I'm saying. That is true. But in the previous session, that is what we were talking about. That there was data for that. But it is important to know that the patient is continent, and only then you give adjuvant radiation therapy.
but then even if we would, of course, continence will become worse after radiation
Yes.
if it is already incontinent.
Yes.
But that doesn't preclude you from omitting. Radiation has an impact on the cancer outcome, not just the quality
No,
of life.
that is why early salvage is to be contemplated, because such patients will they will perform equally well with either adjuvant or early salvage.
This is early salvage only.
No, this is 0.28. It is not early salvage.
So
it is salvage
what you are mentioning, see,
Hanji, Hanji.
it is. No, what is
just 1 second.
no,
Just 1 second.
See, what he is saying is correct. The intention is adjuvant, but fortunately, what happened? Patient had PSA rise very early. That's why it turned out to be early.
Definition of adjuvant is PSA should be
Undetectable. Yes. So
yes. Should be continent, and then you give that will be called
is adjuvant.
Whereas early salvage is the recurrence has taken place.
So if we, in the immediate post-op period, if his PSA was 0.04 and you said ये continent ab radiation दे रहे, it is adjuvant.
This is adjuvant,
Yes.
exactly. Salvage is when the PSA has risen.
2.1. Early salvage is when you give it below 0.1 or 0.2. Below, after that, it is salvage radiation only, not early salvage radiation.
1 second, can I just...
Yeah, that's what we meant. Yeah, that's what we meant.
I have one question to Ashish. Now, in this particular
Just 1
scenario,
second, let me please just maintain little. So, as a summary, we are talking about salvage radiation here because patient has already relapsed. Early adjuvant, as Dr. Rohit Malde correctly pointed out, there is no as such role of early radiation versus salvage because the only thing that improved was time to PSA progression. Of course, that is going to happen. But salvage RT, the PSA will be further delayed. But other than that, all the other outcomes were not improved with early RT. So more or less, the practice in most centers is salvage radiation when the PSA rises more than 0.1. Of course, we look at the doubling time, but in most individuals, I have not seen actually continence as such a big issue precluding us from giving radiation therapy. Patients talk of incontinence in the immediate period, but not when we see, in my experience, people can differ. And given that this patient is on incontinent, I add that point. Can I request one of the radiation oncologists to talk of the volumes, the dose, technique, and concurrent ADT? Dr. Abrol, you want to take first?
I'll include prostate, seminal vesicle, and lymph node volume into it, and go from 75 to 80 gray IgIMRT. And in concurrent ADT, we will use leprolide along with abiraterone, since it looks to be a systemic disease to me.
So in your practice, in adjuvant setting, would you, or salvage adjuvant setting, you would go up to 80 gray?
75 gray.
75 gray. And you said give abiraterone with your ADT?
Yeah, in ADT.
Okay. Gargi, any difference of opinion?
Yeah, So we wouldn't go as high as 75 gray. It would likely be too toxic. So we would do around 64 to 66 gray. 64 gray is, I think, standard. And now in the radicals, they had even tried 52.5 gray in 20. So that is something we have recently started doing. And coming to the volumes, I would treat the prostate bed as well as the pelvic lymph node volume, preferably with IMRT. Coming to concurrent ADT, in sport, that did show benefit, but then there were a lot of fallacies with the sport trial also, that the patients who were recruited, they were not exactly salvaged. They had PSAs anywhere between 0.8 to 1, a significant number of them. So in some selected patients, I might avoid concurrent ADT.
Okay. So you would avoid concurrent ADT also in this?
Yeah, in certain patients. Probably not this one.
Because, of course, I agree with both of you over the volumes. We would treat the prostate bed along with the lymph nodes. And the dose, sir, I would agree with Gargi because in adjuvant setting, there is a trial which compares high dose with 64 gray, and 64 gray has been the standard of care.
Moderated hypofractionation is nowadays used, which she is talking about.
No.
She's
talking about conventional fractionation.
Or if we do moderate, I would do 52.5, which was used in radicals.
But in which fractionation? 2.2, 2.7?
So 2.5, that would be.
But I think 2.2 and 2.7 is being used most commonly.
Yeah, but the total dose you are suggesting, sir, is quite high.
It may be variable.
It may be variable. I agree. Completely agree.
Excuse
and,
me.
The technique.
What about the dose of the radiation to the lymph nodes? It will be the same what you give for prostate, or is it different?
Would the panelists take this?
Yeah, it would be lower to the pelvic lymph nodes considering the bowel toxicity. So normally when we use 64 gray to the bed, we give around 55 gray to the pelvic region. And when we are using 52.5, we give around 44 gray to the pelvic region.
Usually I go up to 46 gray to lymph nodes, volume, including lymph node volume, and then boost the prostate and seminal vesicle up to 54 gray, and only prostate for the rest of the dose.
Beyond. We are talking about post-op, yes. Yes, sir. Yes, sir.
ADT, in such a case, should be used for 4 to 6 months.
And she said no ADT.
She said in selective cases, I might
No, but in this
omit
particular
ADT.
case, she
In
would
this
not.
case,
So can you take me to the molecular level? How does it help,
Sir,
ADT?
medical oncologist can clear it, I think.
I think
No,
every urologist here writes more ADT than us, so let them answer it.
No, how does it help in radiation, ADT? Just take us to the molecular level.
yeah, so no, in
And
this
because
case,
I have seen radiation oncologists giving it for 3 months, some give for 6, some give for 2 years. So, I mean, there is so much of difference in opinion. I thought only surgeons may differ, but...
Sir, you're talking about post-op setting?
Yes.
Post-op setting.
Yes.
so
There is no standard duration what has to be given. So, all...
One of the experts did mention that based on the Stampede, one of the data set of Stampede, in the post-op settings, there are clear guidelines that you add 2 years of abiraterone, and the indications are any node-positive prostate cancer, any T3, T4 with one of the high-risk feature. One of the high-risk feature is PSA more than 20 or a Gleason grade group 8, 9, 10. These ones. In this, you have to give 2 years of abiraterone, and most of the guidelines, EUA was quoted
So that
by
is
one.
about
that is
definitive
not for
setting.
post-op.
In the
That is not a
post-op,
post-op.
Ajay, now we are talking about the
Post-op.
post-op.
Salvage. We are
So
talking
in
of salvage.
Post-op, there are no
6
standards. So I will
months-
come to post-op. There are no standard
There's no
guidelines,
standard.
but 6 months will be the abiraterone.
and now radicals HT is the one.
So it
which
helps.
is-
3-arm trial, prostate only, arm 1, prostate plus pelvic node, arm 2, prostate plus pelvic node plus 6 months of ADT, arm 3. 5-year weak PFS, 62% in arm 1, 71% in arm 2, and 81% in arm 3. So the standard of care as per the sport trial RTOG 0534 is to add pelvic nodes plus prostate plus 6 months, 4 to 6 months of ADT.
Even the GETUC trial, GETUC 15 has shown 6 months of ADT to be used. So again, 6 months of
Bicalutamide
ADT
was
is where it
used
has come.
and it had shown an improvement
So
in
it
the
is
overall
6 months.
survival as
So if
per
someone
the
is
GETUC
giving-
trial.
So the question remains of sir is that on molecular level, how it helps?
No, it's a kind of a systemic disease. My understanding is the ADT is more for the systemic disease, not the local level. That's my understanding.
You see, again, just talk about the basics. I mean, one of the studies somebody presented, PSMA PET tells you where is the disease.
Yes.
Okay. So it has been my query, and I'm panelists could answer that. So one thing, like if you know the disease in the pelvis, why to irradiate prostate? You know, it's not about the incontinence. Even after radiation, patients have bladder neck contracture, which at times are very difficult to treat. I have patients after radiation, I have done BNI for 13 times. So we should think about these things when it comes to radiation. So why not only irradiate what is visible? That
Sir,
is one.
actually,
Another question.
yeah.
I mean, that
Okay.
could be interesting. The second is why wait? Why not wait till PSA goes up to 1, get PSMA, get the lesion, and irradiate that? That's the
So
question.
both the points have been.
Sir, it's only various trials have shown that if we'll irradiate, that will be beneficial as far as.
We had trials which said adjuvant RT is beneficial when it comes to survival. Now, I think the world is going towards salvage. I don't think in coming future radiation, anybody would be giving that adjuvant radiation.
I think radiation will be coming up in a big way, sir, because the techniques are so advanced and
Sir, we are talking
computer
about the same
algorithms
thing.
are coming in
Salvage
such a
will
nice
come.
way that I think.
Hello.
So they have this concept that the thing is you treat the disease only if you can see it.
Exactly,
So this
that's
is,
where
do
we
a
are
PSMA
heading.
CT PET scan, and if you see the disease, you treat. And if you don't see, you keep repeating the PSMA CT PET scan till you see the disease. As long as it's restricted within the pelvis, you would treat with adjuvant. But it's a trial. It's still not started. So these are just preliminary discussions, and risk holders are having these meets and meetings.
Yes, sir, exactly. So this is the hypothesis now. So many a times when they have done the PSMA PET, there are some studies which have showed the next question exactly is how often do you find a PSMA PET positive focus? And then many a times in studies almost to the extent of 40%, it's outside our normal field. So the idea is slowly moving towards wait and then let the PSMA PET light up and treat because maybe we are over treating the bed and missing out on some points. That's the future I'm saying. I'm not saying this has come already, but some articles do discuss this. Presently, 100%. I completely agree. Just that the volumes will change based on PSMA PET. As of today, the practice remains. We observe the patient after radical prostatectomy. We do not give adjuvant radiation. We wait for the PSA serial monitoring. Once the PSA rises above 0.1, we give salvage radiation therapy, and it has shown improvement in across studies, and that with concurrent ADT for 6 months. That is the present standard of care. If anyone wants to disagree.
So I think the future is not going to be all the future is going to be liquid biopsy, ctDNA, and genetic testing.
So we have had patients who have had PSMA PET at 0.46 PSA post-op. They showed a lymph node in the left external iliac region. We have just given radiation to the lymph node, and they have still had progression on of PSA, and we had to start them on ADT. So a PSMA PET can be oversensitive, can pick up things that are not actually disease, and there is the other way around also. It may not pick up disease that may still be there.
But why would you treat only the external iliac? That's not the standard of care.
No, that is what I said. You were saying that we treat only what we see, and we did
No,
that.
we
in
are not
a-
advocating.
Do
No,
that in
no,
the
no.
present era. This cannot be done outside
Because
of a
any
clinical
microscopic
trial.
foci will be in the bed. From that only
But
it's coming.
In that case, there was no adverse pathological factor in the prostate itself.
But
it was T2.
But now you are seeing a gross node, right? You are seeing a gross node now.
That would be an
We can't treat every
non-standard of
patient on
care, I would
anecdotes,
say.
Dr. Saab. So this is a one case, na?
It is okay, but discuss kare to I'm
No,
also
of course, it's good that you raise the point, but in a patient who has had a recurrence, PSA is 0.04, sorry, PSA is 0.4, you are seeing a focus on PSMA PET. We would treat, any radiation oncologist here would treat the prostate bed
also.
along with lymph nodes and probably giving a boost to that lymph node that you have picked up,
Very
right?
true. You have to do the whole pelvic nodal. There is
point-
no point skipping.
So we cannot skip the radiation there in the present standard of care. So this author, I think we've already covered. So the volumes might change based on radiation because of paucity of time. Just to the medical oncologist with us, Dr. Vamshi Krishna. So in Formula 509, patients had a PSA of greater than 0.1 post RP and one of the unfavorable risk factors, and they implied a benefit in subgroup of PSA in the subgroup with PSA greater than 0.5. Any thoughts on addition of abiraterone in the present setting?
I wouldn't add it. There's data from Stampede that addition of abiraterone and enzalutamide doesn't help. So enzalutamide plus abiraterone in the Stampede trial is showing no benefit over abiraterone alone. So number one, I would not do this. If you want to do it, add only abiraterone. Again, this study was not powered to design it. The study power itself, they said it should be 0.5 and they did not meet it. So again, I would not use in this scenario. This is exactly what we were discussing in the previous discussion. Somebody was saying it's high risk post RRP, give abiraterone also.
Yeah.
It sounds logical, we don't have evidence for it.
Yes, exactly. So presently, we do not have any evidence of adding abiraterone, apalutamide, enzalutamide. This is what a radiation oncologist pronounces a chemo drug in this setting. APA, ENZA, yeah. So I think we would not go into this because pertaining to the trial, but other settings, abiraterone, as it was mentioned by Dr. Sandeep, that it is the standard of care in node positive and very high risk NCCN category, abiraterone. So coming to the next, it will be very short and sweet. I want one of the two uro-oncologists to take one question. So cancer control outcomes following focal therapy with HIFU. What type of patient you think would be suitable for? I'm assuming none of us here have experience with HIFU, and taking that just on the basis of the knowledge that this trial has generated, which patient would be well suited, and what are the major contraindications?
Only localized is probably limited to one lobe, not extending beyond the capsule. Probably a very limited disease we can think of HIFU. I don't have much experience.
If this was available, would you try based on the evidence, or would you go ahead with a prostatectomy? I would rather radiation.
Whatever we are comfortable, we should do that. That's the answer.
You think it is...
In Delhi, they are doing...
12? Pardon? Yeah, maybe not the updated one, but they have been doing quite a few early cases of CA prostate with HIFU. It was more, they were doing it in the earlier years, but recently I think they have decreased the cases.
They have decreased?
Yeah, because I think one session was not enough and then multiple sessions were needed and also some complications. So they're not doing it as a routine as of now.
So which cases would, I mean, as a GU team, would you send for HIFU? I mean,
personally,
with no
I would not,
experience.
yeah. I would radiate, like how you said.
Whatever theoretical knowledge is very limited disease probably would consider. And screen detected patients, patients with very low PSAs.
And can someone, so how do you say HIFU playing a role in prostate cancer treatment over the next 10 years? Anyone wants to take it? Dr. Mukul, if you have experience, do you want to take it? Role of HIFU in the next 10 years?
She said it has gone down.
That's what, but this trial, yeah. But what is the advantage of, I mean, I'm from a total learning point of view, what is the advantage of HIFU when, you know, we have non-invasive other methods available, if invasion is the point?
So that is one of the issues. The point is of focal treatment. The point is not treating the whole gland. So when you treat the focal part of the prostate only which has tumor, then the side effects are practically zero. So it's even less than radiation. So, you know, so that way, that's why the patients are driving it, that they have absolutely zero side effects.
But the second HIFU rate is also high,
There is
right?
no, it's very minimal. If you see the long-term studies, the second HIFU rate is not that high. But of course, to do surgery and things after that, it becomes more and more difficult. So failure rates are pretty good at 5 to 10 years. We are looking now for 15, 20 years, and after that, only then we can compare with radiation and surgery. So it's still a long way to go for that.
I will beg to differ because majority of the lesion, they are in peripheral zone. They are close to the rectum. And in HIFU, the disease should be fairly away from the rectum. So rectal injury is the major concern when a patient considers.
But it is through a
That is
probe
with
in
the older machines. The new machines, there is no rectal injury. Rectal urethral fistula is less than 0.1%, which is probably similar to radiation.
So we have recently bought the third generation HIFU machine at Rajiv Gandhi, and we have started doing HIFUs. So it is now indicated, as sir said, for focal cases. It has to be HIFU is primarily for peripheral zone only. When the lesion goes anteriorly, you go with cryo or irreversible electroporation. So for peripheral zone lesions that are occupying low volume disease 3+4, 3+3, high volume 3+3, you can target that quadrant of prostate, ablate it without damaging the nerves on the other side. So this patient will be continent, will have his normal erectile function. A second HIFU can still be done. If the patient fails after second HIFU, he is still a candidate for surgery as well as radiation therapy. So these patients do quite well from the data in the literature. They'll go, the second HIFU is normally needed after a median point of 6 years. Until that time, he is continent, his erectile function is good. We treat them around younger patients, 50, 55, then they are 60, 61. They don't mind getting radiation or surgery done and can still survive for long periods.
Ritika, this
thank
says
you for
Kaplan-Meier of 7 years, 69. If it is a T1, we have 15-year data of 85 plus. So why
they are,
do this?
so that
And
was,
they are comparing radiation, we are treating whole gland. If you treat focal radiation, it will be less. But it's not yet proven.
so it is another non-invasive technique that is coming up, and the question from my end was that the same, that why, what is the,
it is invasive.
it is not it is non-invasive, sir. So going ahead, due to lack of time, just last 5 minutes, and we could later discuss amongst ourselves if required. So superior post-treatment biopsy outcomes with high-dose SBRT compared to high-dose conventionally fractionated IMRT. Just quickly from one of the radiation oncologists about practice of SBRT in your patients, and who is an ideal setup, and otherwise what do you do? And also the next question, just because we are running short of time. The multivariate analysis in this study showed concurrent ADT in both groups, which improved post-treatment biopsy rates. So do you in your practice, I'm aware TMH does SBRT considerably. So in your practice, do you use ADT? Because PACE-B, hypo-RT-PC, and the prospective study meta-analysis all had disallowed from use of ADT. So what's your experience?
Yeah, but the data for using ADT is much stronger so far what we have. So we do use ADT, what is used in the normal hypofractionation.
So how long do you use?
2 years for high risk and 6 months, 4 to 6 months for intermediate risk. So SBRT we do as a standard only in intermediate risk, and in high risk only under trial setting. So I would not feel comfortable omitting or shortening ADT in high-risk patients.
So you do use ADT in all your cases of SBRT?
Yes.
And you would agree, sir?
I don't use
SBRT, okay. So ADT, I thought, influenced the outcomes in this study significantly. And otherwise, in all your intermediate risk cases, you use SBRT?
Yes.
As a standard of care in all intermediate risk groups? Okay. Any radiation oncologist has any comment to make about the use of SBRT in all intermediate risk? Okay.
Actually, SBRT is a good proposition, but it should be done at a good center with higher clinical expertise and physics expertise.
I agree, and I think too that SBRT is a well accepted modality in intermediate risk prostate cancer for sure. Of course, there's evidence from TMH for high risk also, but as a general practice, we are wary of doing it in high risk yet, but intermediate risk, definitely yes. We have already covered the implications of positive post-treatment biopsy. I think we'll move on. And sequencing of ADT, I think the question comes for the medical oncologist. With radiotherapy for non-metastatic prostate cancer, the SANDSTORM trial. So, as Dr. Trinanjan mentioned, that we have been using neoadjuvant concurrent more than concurrent adjuvant, and this trial comes and says that, concurrent adjuvant is going to improve everything. So what are your thoughts and practice?
To be honest, we were doing it again based on whatever earlier trials were there. You
Yes.
give the NHT and then you go ahead with the radiation. That's what
Yes.
we were doing. After this, I think we'll have to possibly change our view. We have not read this much in our MDT
Last
for
1
sure.
minute I'm going to take and we stop.
We have not yet changed immediate of practice, but what we are doing now is you give ADT within 1 week or 2 weeks, we are starting off radiation. So
Yeah,
that
we
is
probably
not,
do planning and by end of
yes,
1
within a
month
week
we
or
go ahead with
not even 1 month,
by
within a
2
week or
months.
2 we are starting off
Okay,
radiation
that's
nowadays.
early, yeah. Okay, so I agree on that this is contradicting to what we have been doing commonly, although in intermediate risk we say neoadjuvant concurrent or concurrent adjuvant. Another thing Dr. Trinanjan has highlighted already, that these patients had high-risk cancers, and we are not talking about short-term ADT. In any high-risk patients, do you give short-term ADT? Because this trial talks of significant number of patients receiving short-term ADT with high risk.
Maybe patients with one risk factor for high risk, like a T3A disease or a marginally high PSA.
That is high risk, because the other one falls
But
into very high
then
risk.
we would consider for a short-term ADT, especially if the patient has multiple comorbidities.
Okay, that is one odd patient with multiple comorbidities, but otherwise any 24 months. So maybe this trial per se, I thought the major point was high-risk patients are included, which changes the scenario, and that was very well highlighted by Dr. Trinanjan, that they've not included whole pelvis, not included the pelvis in many patients, and given short-term in only high-risk also. So that kind of is the negative point here. What could be the possible mechanism? Somebody already raised this question. So, sir, ADT, why is it helping, and why do you think concurrent adjuvant is doing better than neoadjuvant concurrent? Any molecular?
I have no idea about this. Honestly, no idea.
So they talk of some extended continuation of RT-induced cell death, but there is no concrete answer for this. Okay, I would thank all the panelists and the audience for this.